I'm Dr. Staci Benson. I have a micro DPC practice in Dallas, Texas. Micro meaning I have no staff, it is just me. And then we have Keese here. He's the executive director of the DPC Coalition. Dr. Erica Bliss kind of referenced him a little earlier today. He's been around since the beginning, helping with Q Alliance with all the ACA changes, and is now fighting for us tirelessly up on the Hill for any DPC need that we may have. So I wanted to be full disclosure. So as she said, I am not on the steering committee for the Direct Primary Care Coalition. I do not sit on any committees for AAFP other than the planning committee for this. I do sit on my Texas ACOFP state board and am active with ACOFP on the committee level nationally, who is also one of the sponsors of this. So these are my personal beliefs and tips for how to work with your legislators. And we're going to start off, though, with the hot topic. If anybody hadn't paid attention, we had a lot of things change up in DC this week for direct primary care. So Jay is going to lead us off.
Great, and I presume you've all read the disclosures, so we'll kind of go right through them. And good morning, how's everybody doing? So Staci asked me earlier today, how long have I been doing this? And I said, well, when did the dinosaurs die? It only seems that long, but thanks to Erica and the folks at Q Alliance, it does go back to the days of the Affordable Care Act, I think around 2009, when I got a sort of a panicked call from a guy named Norm Wu, who at the time was the CEO of Q Alliance, and he said, this Affordable Care Act thing is going to destroy our direct primary care, and I had never heard of direct primary care. And actually, that term wasn't even used yet. I think they called it direct practice. And so this direct practice thing is just going to go away. And, we offer, for $60 a month, we offer complete comprehensive primary care coverage. And I said, no, you don't. There's no way you do that. And began to look at it, and it was very exciting because it was completely different than anything I had seen in 25 years of lobbying and doing healthcare policy work in Washington, because it really was the thing that I thought at the moment would restore the doctor-patient relationship more than anything that had come before it. And we were working really hard at the time on things like ACOs and patient-centered medical homes, and really trying to sort of put some duct tape and chewing gum on the fee-for-service system to make it work a little bit better and perhaps make it a little bit more accountable to the patient. I think what we've found with a lot of those things, although a lot of them have been good, there's been great evidence coming out of places like Vermont and Minnesota with some of the PCMH demonstrations, and there's been some ACOs that have, put, single-digit savings on the board in terms of, improving health outcomes and stuff. Nothing has come to the kinds of outcomes that DPC docs have been able to show, particularly in relationships with employers over the past 10 years, up to 20% savings, even more in some cases. I think if you talk to Erica privately, she'll be able to tell you some of the numbers that they did in Medicaid, even though it was a big cluster, were amazing. You're taking people that have never had a primary care doctor before in their lives, and you're giving them this great access, and you're giving them a personal relationship with a doctor that they've just never had. And I remember anecdotes and stories coming out from Erica and some of the providers about the people would be crying in their offices because nobody had ever taken care of them before. They go to the urgent care, or they go to the emergency room, and we all know those are the best places to go to get really affordable and good primary care. So it's just been really exciting to me, and an honor and a privilege to be able to work with you all and to move a policy agenda that I think is one of the most exciting things we've got going on. And so we did start this DPC coalition, and I encourage you all, as a full disclaimer, I am representing the Direct Primary Care Coalition, and we want all of you as members. And so dpcare.org is our website. We encourage you to go on there. There's tons of resources. There's tons of information about how to get involved in advocacy and what's going on Congress, and how to contact your legislators and that sort of thing. But we need your help, and we need your support. And as many people have said, this is exactly the time when we all need to be standing as one, and with as unified a voice as we can get out of a room of a couple hundred doctors, and go back to Congress and say, we need to be doing everything we possibly can to move this forward. And I think there's a couple of huge things happening, as Staci referenced, that we're going to talk about in terms of the actual policy. But the DPC coalition stands solely to move policies that'll help grow the movement and bring better access to great primary care for Americans of all ages and all incomes. So who likes this? I haven't. It's the oddest thing in my 30-plus years of lobbying that I've ever seen. We haven't found anybody that doesn't like this. Even your insurer former dance partners got up and testified at the Ways and Means hearing on the HSA bill that we're about to talk about and said, this is exactly the kind of thing that we feel we need to move to. Now, they don't do that very well, and maybe that was just some lip service, but you can't really find anybody to out and out oppose this. And so it's working, and it's working not only in private, small relationships with individual patients, it's beginning to scale with self-insured employers. We have a number of plans, even some small DPC practices, beginning to do arrangements in Medicare Advantage and showing the same kinds of savings that we're seeing with employer arrangements. State and local employee unions and employee funds, government employees are taking to this in droves. I think you heard from Joel Bessemer yesterday that the state of Nebraska just passed legislation to do a pilot on DPC for the state employees. It's going to last multiple years. We helped draft that legislation and push it through with Joel and Merv Reapy from the great state of Nebraska. That's their second DPC bill that they've passed. And it's just really exciting to see some of the innovation that's gone on. Companies love this. One of the biggest supporters that we've had lobbying these issues in the last 6 months to a year has been Boeing, one of the largest companies in the world. In the appropriations bill, where we were trying to get this language attached earlier in the year, Boeing was up there, lobbying not for a new jet in the defense appropriations bill, but to get this provision put into the omnibus. So, we've got some pretty heavy hitters that are backing us now. Major employer groups like the National Retail Federation and the National Coalition on Benefits, the American Benefits Council have come and supported what we're trying to do on multiple levels. So we're really excited about working with others who are interested in hiring you to do your services for their employees and the covered lives that they have out there. So we are at the coalition really about trying to integrate direct primary care back into the health system, but to maintain what's good and what's great about primary care being independent and outside of insurance and outside of third-party billing. So initially, as I think we've talked about, we did get this law passed in the Affordable Care Act that essentially says that direct primary care is an essential health benefit that can go alongside a qualified health plan, and it can be offered in the exchanges, and employers can use this to satisfy the employer mandate part of the ACA in conjunction with their self-insured or outside coverage. So since that happened, the states kind of jumped into play, and I know Phil is going to talk about the detail on some of these a little bit later, but we have been able to pass 25 laws, most of which have been passed. Of course, the Washington law was first, and I think we had West Virginia, a very bad law in West Virginia, which we've since modified, and maybe Utah before, or was it Arizona? One of them, I think there were 3 before the ACA. But since then, 25 states, and important to note, at least 3 states have put forth really good regulatory guidance that essentially does the same thing that the state laws that have been passed do. And these laws, just generally speaking, say that direct primary care is a medical expense, it's a medical service, and is not regulated by the Department of Insurance. So we expect at least, I'd say 5 to 10 more that we certainly know about in next year's legislative sessions, which are expected to start in January. We've been working directly with some folks in Arizona about improving that bill, and the other states that are listed here in blue are sort of in midstream when their sessions ran out, doing a bill. Maryland, I know, is going to go back at it again. So we're going to continue to work really hard to pass these state laws. And some of them were put in place because they felt like they needed to reconcile state law with what's in the Affordable Care Act that very clearly stated that direct primary care is not insurance, but is a medical expense. One of the things the ACA has done, like it or not, has really driven the prevalence of high deductible health plans. So we all know that one of the biggest problems that we have out there with DPC is that in the current state of the law, it's not compatible with HSAs. And that's what the Primary Care Enhancement Act is all about. So looking at the rise in trends, we saw last year that the amount of dollars in HSA funds grew by 23% in a single year. This is dramatic growth. By some estimates, I've heard as many as half of all Americans with covered lives in the next couple of years are going to be covered with high deductible health plans that are eligible to be with HSAs, whether or not they take up on the HSA or not. And the law is very specific. So the problems that we've had in the law are that the law says a couple of things. And I'm going to actually read verbatim from... I'm going to actually read verbatim from the bill that we're working on right now, what the problem is. Individuals eligible for HSAs are covered by a high deductible health plan, and no other individuals eligible for HSAs are covered by a high deductible health plan, and no other health plan that, 1, is not a high deductible health plan, and 2, provides coverage for any benefit which is covered under the HDHP. So you're ineligible if you have another form of coverage, which is not necessarily insurance. Under present law, a direct primary care service arrangement is considered other coverage or insurance, and therefore not an HDHP covered person, is not an HDHP covered person and is not eligible to contribute to an HSA. So that's the essence of the problem. So for the last couple of years, we've had this bill, the Primary Care Enhancement Act, which is very simply said DPC is a qualified medical expense under 213D, and under 223C, it is not invalidating coverage. In other words, it doesn't invalidate your HSA, which is frankly the biggest problem. The problem here is that under the law, you cannot fund your HSA if you have a relationship with a DPC doctor. That's one of the most restrictive pieces of the tax code that I've ever seen. So we have pushed this rock up a hill for a long time. I think the first time we introduced this bill was about 4 years ago, but the language that was in it predates that in the Health Savings Act and predecessor bills to that. It goes back almost 10 years. So we've been working on this for 10 years. And finally this year, we got to a position where the Ways and Means Committee decided earlier this year that they were going to move some HSA legislation, and finally we were at the very top of that list, along with a couple of other provisions out there that would expand HSA coverage for chronic disease management services that would meet the deductible and additional items using HSA dollars for sports and fitness facilities, for retail clinics, for telemedicine services. So the Republicans have wanted to make HSAs better, in other words, make them more usable for a long time. And finally, there have been some Democrats who have been opposed to HSAs for years because they feel that the HSA is essentially for the wealthier and the younger patient, and that people hoard money in HSAs and then don't use them to seek appropriate care. So one of the things that's great about this provision is it says, hey, we're going to let you take money out of your HSA pre-tax with a great triple tax preferred health benefit and spend it every single month to get good primary care. So the Democrats have really been attracted to the idea that, hey, we're going to be moving people, and even people of relatively modest means. I think the average income of an HSA is now for a family of four is like $50,000, which is squarely in the middle class range around the country, and more employers are going to it. So the income levels of the HSA holders have come down, and everybody realizes that this is a problem that needed to get fixed. So what happens when you move legislation? And we'll get into this a little bit more with Staci. We'll talk a little bit about the process, because the process here is, as we know, is very clunky. This is a revenue bill. It's a tax bill. It has to be introduced in the House, so it has to start in the Ways and Means Committee. So the first thing the Ways and Means Committee needs to do with this bill is they mark it up. In other words, they hold a meeting and they take the original bill and they enter what we call the amendment in the nature of a substitute. So when they amended the bill, the primary concern that they had was what we call the score. So the score of the bill is how much it's going to cost. And in this case, because it's a revenue bill, the Joint Committee on Tax took a look at our original legislation and said, well, we've got to make some changes to the legislation because as written, it would be a budget buster. We're going to take triple tax preferred income that's going to go into HSAs, that's going to drive up the amount of dollars that are going into HSAs because they assume that what you're doing is a really good thing and that people are going to want them and that it's actually going to drive HSA growth. So without some of these changes that were added to the bill, and the changes make the bill far from perfect, but still allow it to fix the underlying problem. Some of these changes were done because the score of this bill, even with the changes, was $1.8 billion in lost revenue to the Treasury over 10 years. Now, how can that be? Well, I'm not sure I share JCT's assessment of the amount. We've talked to other economists that don't think it's that high, and they give us absolutely no credit for doing good healthcare and creating savings downstream, because all they're concerned about is the revenue to the Treasury. Does it cost revenue? It certainly does, and it certainly will. So in order to keep the score down, they put a cap on the amount that would define a direct primary care plan. So this exception to the idea of a health savings account, a DPC plan, invalidating eligibility for an HSA, is that the DPC plan would have to be limited to just primary care, and it would have to be limited to $150 PMPM or $300 for a family plan. And they split it up that way because that's the way HSAs are split up. There's an individual HSA and then there's a family HSA. And again, it's restricted to primary care services only, but it does say very specifically DPC arrangements are considered medical services and not a health plan. Now, we haven't gotten the technical advice back from IRS yet to make sure that the language is exactly right. But again, I'm going to go back to the JCT definition that was read at the markup of what this exactly means. An arrangement under which an individual is provided medical care consisting solely of primary care services provided by primary care practitioners, and the sole compensation for such care is a fixed periodic fee. The aggregate of all DPC fees for all DPC services cannot exceed $150 per month, twice that or $300 for a family, and amounts are adjusted annually for inflation. The term primary care services does not include procedures that require the use of general anesthesia, prescription drugs other than vaccines, and laboratory services typically not administered in an ambulatory primary care service setting. The aggregate fees paid by the employer for the direct primary care service arrangements will be provided in connection to an employee. With employment will be reported on Form W-2, and the effective date will be December 31st, 2018. So while it's clunky, and while we do not like the idea of the cap, we also don't like the idea of the cap being in the definition, as opposed to the cap being a cap on the pre-tax amount. We think there can be some changes as this moves forward, and understand that this is really just the first step in the process. It's been marked up. We do expect them to move on this legislation on the House floor quickly, and we do expect that it'll pass. Then we've got to go to the Senate. And you've all heard the Senate has a little bit of a chore in front of them, nominating somebody for the Supreme Court, which is going to suck up all the oxygen in the room, probably through September. They also have to do a budget or a continuing resolution. I think the high likelihood of the future of this legislation in the Senate is not exactly the same way it was as under regular order in the House, where we had a bill, we marked it up, we sent it to committee, we got it out of committee, we amended it, we fixed it, we did our technical and conforming amendments, we got it on the floor, we voted for it. Does anybody know, what is COBRA? Anybody tell me what COBRA is? I didn't ask what it stood for, but it's extended healthcare coverage. If you lose your job, you get to keep your healthcare coverage for I think 18 months, right? But John's exactly right. It stands for Consolidated Omnibus Budget Resolution. It doesn't stand for anything that has to do with healthcare. It's because that provision was dropped into an omnibus budget bill. I think the high likelihood that this legislation moves forward, it's going to move forward in a budget bill or something that's going to happen at the end of the fiscal year in September, hopefully, or perhaps even in the lame duck, because the more likely thing that Congress is going to do is come back September 30th, pass a continuing resolution until after the election, go home, try to get reelected in a very volatile electoral environment, and then come back and do things in the fall. I actually don't believe that if there's a flip in Congress, that it's necessarily going to put this thing in peril. I know there aren't as many Democrats that support this as Republicans. I think it's realistic to believe that there's a lot of Democrats that have co-sponsored this bill. We had a lot of Democratic Ways and Means Committee members that stood up and said great things about this. I'd urge you to go to the Ways and Means Committee site and watch the markup. Earl Blumenauer from Oregon and Eric Paulson, our sponsors, said great things about this movement and what it's doing for patients. So we've got good buy-in to move forward with the bill. So I do think it's imperative that we try to get this done by the end of the year, and because Congress is going to have an entirely different set of priorities and agendas as it starts next year, and if one or more of the bodies of Congress do change hands, it's going to take them 6 months to figure out where the bathrooms are. So it's going to take a while to get back to this. So it's a really good opportunity to move the bill. We know the bill is imperfect, but as it's drafted, it really fixes about 99% of the problem, and we will be able to come back and try to work on fixing it. I think you all heard Erica's example about the initial law in Washington didn't allow this to happen with employers. They came back and they fixed it. So we all know that this policy stuff isn't going away. We're going to have to continue to work on it, and we really appreciate your support and your help, and we're going to need your help as we move this thing forward, as imperfect as it might be, knowing that we want to make sure that the perfect isn't the enemy of the good. And with that, I think we'll pause a little bit. I know this is a pretty controversial provision. There's probably a bunch of questions out there, and we'd be happy to take some questions. And then we're going to talk a little bit about how we do the advocacy stuff.
And we'd also encourage people to come up to the mics. We're going to put a time clock on this, and then we're going to go on to the second half of the talk. But feel free to come up to the mic and ask a question. Yes, from the middle.
Yes. I'm Chris. You and Jay, we know each other well. This bill is going to be pretty tough on us, and I want y'all to we're going to have to think through this because it's hit us. Roy Rantham and I came up with the bill to try and let us have our services covered on HSAs. This started about 12 years ago. Roy Rantham was in the White House. He was Senior Healthcare Policy Advisor in the White House. And I came up to him I was president after Garrison Bliss, third president of the AAFP. And long story short is that we wanted to keep this simple. We really wanted to keep this simple so our patients can just say, we're covered. We all get that. But by putting in the $150 per member per month cap is going to be really, really disturbing and troubling, I think. The first bit of advice we got on this 15 years ago was don't let someone else tell you what you're worth. We are all family physicians, and this is the government telling us what we're worth, and I know this is going to be a big discussion, but it's disturbing.
So I'm going to actually turn that into a different question since it was more of a comment, and we've already mentioned that the DPC Coalition, along with most of the practicing DPC doctors, agree that we don't like the fact that they're capping what we charge, even though most of us do charge less than that. So a question we have is, if a practice were to charge more than the $150 cap, what does that mean to the practice and its members, assuming this does go through? Yeah,
so first of all, this is only limited to your patients with HSAs. It doesn't apply to any other part of the law. So it's limited to those patients with HSAs. And if you have a lot of patients with HSAs, they're going to have to be restricted to these guardrails. And a little bit of an answer to Chris that's related to this, I can give you 1.8 billion reasons why that cap is going to stay in there in some way, shape, or form. We're hopeful to move it so that it doesn't actually define in a box what a DPC practice is. So the way it's drafted, if you're $150 per member per month, or $300 for a family, you are an exception to this exclusion from the HSA provision. If you're 151, you're not. So that's arbitrary. We don't like it. What we would prefer, and we think it would have the same effect of the score, and we're going to try to do this as we move the bill into the Senate. What we would prefer is the IRS just simply say, up to $150 pre-tax can be used out of your HSA in a direct primary care arrangement. And doesn't that sound a little bit more reasonable? I mean, I know we don't like the idea of any kind of limits, but let's face it, we're not in a budget environment that's going to allow us to operate without limit. And the first question that we got from the scoring folks is, what's to stop Kaiser from taking advantage of this provision? What's to stop somebody that's providing things way beyond the scope of primary care? Because their assumption is when you give people a tax benefit, the lawyers are going to circle around it and figure out how everybody can get that. And they're absolutely right.
Take a question right here.
Is there a question about states? Ohio. There are many in Ohio who say, don't do a law for DPC, stay under the radar, and I kind of wonder, why are we saying that? What's the process to say, don't define it as a law in Ohio?
I'm going to actually, I want to defer that question for Phil, who's going to have a conversation about the specific state laws.
So he's in the after lunch in the 2 sessions. There will be a lot more specifics for people that are just getting into practice, wanting to learn more about the legalities. And
we'll be available for more questions on the HSA stuff at 4 during the break. Phil and I'll hold a little off the floor session.
Back microphone.
So all the state questions we hold for Phil, or is that?
Yeah, let's keep this to the HSA, a provision, and we'll move back and,
Okay.
Thanks.
Strong work, Jay. That was a great job. And I think most importantly around the room, a lot of us could disagree with the cap. But I think the thing that you need to understand, and Jay gets this, is that if you're going to lead legislation through, you got to get it through the frickin' committee and out to the floor, and you can still change the bill. If you don't like it, call your senator, call your legislatures, get the damn thing fixed. Don't get pissed at Jay. We're doing the best job we can do right now to get it out of committee. And I am here to tell you something right now is better than nothing. Otherwise, we still have nothing. So please, don't direct any disconnects this way. Get after your senators and your legislatures, and let's get it changed. Let's get after moving it up to what you think it should be. And I love the idea of at least getting it to up to a certain amount of dollars. Thank you very much for your leadership.
Thanks, Joel. Somebody gave me an analogy at the markup about this when we talked about not liking the cap. It's like you're wandering through the desert and somebody comes up and offers you 3/4 of a glass of water. Are you going to drink the water and make it out of the desert, or are you going to pour the water in the sand? So as you ask your senators in particular, I think, to look at changes of the bill, we would ask that you ask nicely and say, we're really happy that the bill is moving forward, and there's a few minor technical corrections that we'd like to fix in the bill. I would ask that you not say, well, we oppose this damn bill until you fix it and do what we want. Because there is a nuance there, and there's a difference about how we have to behave as civilized people when we talk to these folks, because they want to do it for us.
So I'm going to ask a question from here real quick, and then we'll come back over to the front mic. So did the new language mention pharmacy was excluded from a DPC practice? Because I know this has been confusing for a lot of people about itemizing.
Yep. So as drafted, the way we interpret the bill is that you will not be able to include pharmacy services in the agreement. It doesn't mean that you want, and my understanding is that most DPC practices actually do this on a pass-through basis, where they just give a list of prices that your patients can go out, and this is the way my Matt Hayden, my DPC doc, does. Just here's the prices for the meds, and you go out and get them. You go out and get them through a mail order arrangement or through GoodRx or another service. So we don't see this as a major drawback, and remains to be seen as we move through the process of the regulation as to whether or not we can charge separately for things that are not part of the agreement. It could be held up in the solely language, but I see Phil stepping up, and he might have a comment on that.
The general comment there on the carve-outs is that they don't want those to be in part of the monthly fee.
Which none of us want, right?
And quite frankly, neither does your state insurance commissioner. If you start bundling labs, if you start bundling meds in there and you're promising that up front, then you expose yourself to risk that the price of Plaquenil skyrockets, and now you promised you're going to provide that. So it puts more risk in your practice. The better way to do it is already to itemize it, and that's what most software does. That's what most people do, is they're itemizing it, passing it on. And an oh, by the way, is when you itemize things like that, the IRS already sees that as a cash pay fee for service, which has never been an HSA problem. So the fact that it's carved out of this isn't a new problem. They're just clarifying that that shouldn't be part of the monthly agreement. Just like if you want to start doing colonoscopies and you happen to do them with general anesthesia because you prefer to do that, there's nothing that prohibits you from opening a surgery center and doing that and charging cash pay fee for service. They just don't want to see it in the monthly fee. And all that, the rest of that, of course, is HSA usable too.
And that goes, I know we also got questions about, so if you do OMT in your office and you charge extra for that on top of your membership, you can charge extra for that. So any of those extra things that you do, joint injections, if you do cosmetics, that's not what this bill is talking about. They're saying that's fine. Continue to use that for your HSA and fee for service as long as it is currently one of the qualifying things. Yes.
So Dr. Julie Gunther from Spark MD, I actually am a board member of the coalition, and I wanted to make a bit of a feisty point about the cap. Well, I don't love it. If you take $150 times 600 patients times 12, that's over $1 million. So I understand what we're saying about the conceptual cap. Nothing else in HSA utilization is capped. But unless you're making $1 million in this room, this number numerically values you infinitely higher than you're presently being valued.
The present cap of 0.
So we're going to do one more question, then we're going to the second piece of the talk, and then we're going to do questions again at the end. So don't worry, I haven't forgotten about these other ones. Did they define a family in the current markup?
More than two people.
But they didn't put a cap on family either.
Say again?
It didn't limit how many family members or say it's grandparents or anything like that.
It's more than one.
Okay. All right. So our next piece of the talk we're going to move on to is, now that you see that advocacy matters, right, as we've talked about already multiple times today, how can you play a part in this? And so advocacy can happen in so many different levels, and we each as physicians need to be thinking about how we can do this on a daily basis, not just for ourselves, for our fellow fee-for-service docs, for our DPC service docs, for our patients, for our community members, for our non-patients, right? We should be advocating on a regular basis. And you do that already. Who in here uses fee-for-service but tells their patients about GoodRx? That is a form of advocacy, right? You're finding a way for your patients to save money, to better their health care, to also save their health expenses, right? You're already doing it. So now how can we take that a step further and join us into the movement for actual federal or state legislative change? So here's just a few pictures, I'm sorry, one's a little blurry, of some fellow DPC docs that are out there advocating. This is just this year, actually. I just pulled some random photos from our Facebook group, which, disclosure, I am an administrator for that Facebook group that's been mentioned. So we have people that have been meeting with their senators, with their representatives. They've been meeting on a state level. They've even gone to the White House or HHS to talk about direct to primary care and how it can impact our patients, our community, and fellow physicians. So while I don't need you to be on this slide next time we give this talk, I need you to all be helping on one way or another from your couches, okay? So who are your legislators? That's the first thing you need to know. You can go to either one of those websites that are there. It's the same website. AAFP has a link. And then, of course, you can just Google your address and who is my senator, and it'll pop it up. But find out who's representing you. If you don't know, that's our first issue, because you should be voting and you should be knowing who's winning your elections, right? But find out who's representing you at the state level and the federal level. The second thing to think about is you need to also think about advocating for direct primary care on a local level. So know who you're voting into office on in your county, in your city. Who's sitting on the school board and running the ISD, right? Who's sitting on the hospital boards and running your administration for the hospital? You're still going to be doing advocacy work with them too, because we want everybody on our side and everybody fighting together. Who is in charge of the medical organizations and even the PACs associated with the medical organizations? And what medical organizations do you align with when you're thinking about their lobbying efforts, right? There's tons of people that represent us on a daily basis that we have a voice that matters. We're voting a lot of these people in, right? So know who represents you. Direct primary care is not just about HSAs. There's lots of topics that affect direct primary care and physicians and our patients. So while HSAs right now is the hot topic and is right at the top of it, there's many other things we need to worry about. So some of those state questions referred to, is direct primary care going to fall under the guidance of the state insurance board? Some states that still matters, right? And so we still need to be advocating for those states so we can help DPC flourish in those communities too. In-house dispensing. There are some states, such as my state of Texas, where I can't dispense medications in my office over than 72 hours worth of meds, even if I desperately wanted to, right? Business taxes matter. With the tax bill that went through, it affected us as professionals and as business owners. We need to be advocating for that. Scope of practice is a really big one, right? It doesn't matter what you practice, scope of practice issues matter for you. It doesn't matter your payment model. If you're going to have someone else coming to do your job, that matters. We also have, most people in here are old enough to remember SGR, right? Come on, you advocated for yourself on that one, right? So we've pushed through that, so let's continue to push through and fight for other things that continue to increase our revenues and help our patients. Okay, so how do you influence your legislators? This is a question even my husband asks me all the time because he doesn't get what I do, but it really is very simple. So the simplest things I put at the top. You can volunteer on their campaign, right? That could be just going to sit at the booth at the local 4th of July fair and handing out flyers about them. You can donate money to their campaign. You can donate your time to their campaign and actually go and do, on a federal level, you can go to another state. Like when I was in college, I actually don't put political opinions into this, but I volunteered to work on Bush's campaign, and I went and lived in Wisconsin for 3 weeks and went door-to-door knocking. I'm from Texas, and I had a great time. You can also throw or attend campaign events, right? This is a great way. Politicians love this on any level because you're introducing that politician to your group of friends, but you're likely like-minded. So if you're supporting this politician, they're likely going to support them too, or they're able to get their ideas into people that previously may not have supported them. You can bring guests to other campaign events. Nice, easy way. Politicians love this. Some of our college friends are pretty high up in the DC area, and to them, that was the biggest piece. They love it when their supporters bring guests to the events they've already put on, right? For the same reason we just mentioned. You can offer yourself as a resource on healthcare issues. This is the simplest to do. Call, introduce yourself next time they're in the office. Say, hey, I'm Dr. Benson. I'm over in the East Dallas area. If you ever have a question about direct primary care, how HSAs relate to it, I am more than happy to answer the question. Or pick another hot topic. If you ever have a question on opioids and how that affects our community and your constituents, please feel free to give me a call, right? They don't do this on a daily basis. They don't really understand what these issues are. They're politicians. The vast majority are not doctors. You do have some overlap, though. And make sure you're always staying in contact with their staffers because their staffers are really who's turning the head. The same way as primary care doctors, it's really hard to know everything, but we're expected to know everything. Same for a politician. They can't know everything about every issue that's going on, so they have staffers that are keeping up to date on the different bills and how that affects their constituents. Okay, so make sure you know staffers. Before you go talk to somebody, whether it be the staff or whether it be the actual member, make sure you know yourself and know the organization that you're representing if you're representing one, right? You need to know your own biases, so that way when you're in the middle of a conversation, you are able to interact more appropriately. If you're going to be very hostile against fee-for-service or hostile against DPC, you don't want to come off that way. So make sure you recognize where you could potentially have a conversation go wrong. And then, of course, be aware of your organization's platforms. For example, AAFP has multiple things that they support, including some of them that don't align with direct primary care. So you have to be ready for that question. Well, you're here on behalf of AAFP, but they really support CPC+. So which one are you wanting to support, right? You have to be ready to answer that question. Know their other stances is how it affects yours. On top of that, you need to know your issue, right? We don't always know everything. The same way when your patient comes in and asks me a random question about some random supplement I've never heard of, I'll get back to you. And make sure you get back to them. Find out the answer. There's nothing wrong with not knowing the answer, but know as much as you can before you go in. Nothing wrong with that. Know your legislator and where they stand on issues. So a great way to do this is looking at their websites, and they'll have nice itemized bullets for their beliefs on issues. You can also look at their voting records. That's a little more tedious personally, but it's really easy to go look at their websites and see where they stand. Know and then look at that stance and look at what your issue is and know how that's going to affect their community and their voters, right? Because as we talked about, it's all about getting reelected, unfortunately. So you want to make sure that you're pointing out that this is a positive thing for the people they support, not just for you as an individual. And then, of course, know your opposition. Know the reasons why people think that what you're doing or want to support is a bad idea, so you can be ready to have a comeback to the negatives. So I just went and pulled Ted Cruz's website. This is something that I always make sure and I have in hand whenever I go talk to his office because they are a good supporter of DPC, but not always. So I've highlighted in yellow straight from his website that he wants to encourage meaningful reform to expand health savings accounts and allow individuals to purchase insurance across state lines and make health care more personal, portable, and affordable. Does that sound like anything we know? So I really remind them of this every time that you're putting it public knowledge that this is what you're supporting. You didn't put a name on this, but this sure does sound like exactly what I'm doing. So you should be doing everything you can to support what I'm doing. Because your constituents that voted for you want this. So now you have to contact them. You've prepped yourself for the meeting. You can set up a personal visit. They have home offices, so in your city or in your county. Or you could go up to D.C. You can go down to your state capital, right? So wherever you want to do, the personal visit is the best. But sometimes it's just not feasible. I would recommend setting up that visit in advance because time is very short. However, if you just happen to be someplace and you want to try and pop in, there's nothing wrong with that. There may be a staffer that has a few seconds that can talk to you about an issue. Be ready with your elevator pitch. Not a problem. If they say, no, we don't have anybody today, make sure you get a card for somebody and you follow up with email or give them a phone call afterwards. Okay, personal is always best, right? Just as we know for medicine, we like the in-person visits better, but there are other avenues. You can call them. You can send them a letter, be it email or a physical, good old-fashioned letter, fax, whatever you want to do, right? But you always want to try and be in contact with them about the issues. Or say you're at that 4th of July festival. So I was at a 4th of July festival just recently. There was a lot of politicians there that were trying to get, starting their campaign. And I hit every single one about dispensing in Texas and why it mattered. I did not anticipate doing that day, but they were all there, so I hit them. If you ever see an opportunity pop up, make sure you have your business cards on you, make sure you have your elevator pitch ready to go, and go explain to them why it matters and why you need their vote. I don't know which of them are going to get elected, but at least I've hit both sides of the party.
I wanted to make a quick note on the physical letter. While in state legislatures this might be okay, if you send a letter to a member of Congress, it goes to Ohio to get irradiated and checked and all this stuff. Do not expect an answer for months because it doesn't get there quickly. An email is definitely the resource that most staffers use other than phone. And if you go on the dpcare.org website, there are links to all the appropriate staffers' emails there, and there's resources and tools to use at both the AAFP and the Osteopathic Association's website as well.
Yep, and I have some of those up in here too. So I've just pulled some old emails, so excuse the dates on these. So also take advantage of these organizations, whether it be the DPC Coalition, the DPC Alliance, AAFP, ACFP, AOA, AMA, your state organization, whoever you want. They all have political action committees that they're trying to fundraise for, and they all send out emails about, hey, we've got an advocacy thing going on. Make sure you contact your member today. So this was last week, I want to say, where they emailed this to me, and I click that Take Action button, and sends me to a form letter. So they've already, you can change it if you want, but it's a form letter on AOA's stance on the issue. And it automatically, you put in my address, it auto-populates who the email is going to go to, and I click send. I've timed this. These take about 23 seconds if you don't edit anything. You just put in your personal contact info, right? There's no reason you can't be doing this from your couch. No reason. In most of these political action committees, if you get on their email list, they don't care if you're donating. They want you to support them with your grassroots efforts of clicking that Take Action Today button. So go sign up for all of them, and you can pick which ones you click, but there's no reason you shouldn't be clicking. You should also be then forwarding this email to all of your friends, right? Especially people that agree with you and say, hey, make sure you've clicked this link. I have gone to the point of putting it on my Facebook page for my clinic. And so anybody who follows me, patients, friends, random people, right, here's a link. If you support this, which they probably do because you're supporting things you're advocating for your patients, please consider clicking this link, right? You're giving them the option, you're just giving them some knowledge that they can work with. So we've actually made our visit. You've told them your issues in your email when you set up the appointment. When you get there, these are just super basics. Y'all can read through this on your own. The biggest thing is please never apologize for taking someone's time. This is their job, okay? Never say you're sorry. You thank them for coming in, but do not say you're sorry. Don't go in with a negative, and that already implies a negative. You say, thank you so much for seeing me today. This is a very important issue. I'm so glad we can discuss it, and go on with your short little pitch. Make sure you know the bill number. If there's a bill that's already been put into play, you might be coming in to ask for a bill to get put into play, such as dispensing. I'm getting ready for next session. And then always share a story, whether it's a personal story or a patient story. A quick little story to associate why it matters goes a long way. And then if a staff member happens to tell you something and they want it to be off the record, keep it off the record, right? You're going to alienate somebody really quickly if they tell you something and you don't keep it off the record. When you leave the meeting, when you're in the meeting itself, you don't want to be taking notes, right? Just like when we're in the exam room, it's best if you don't have your laptop in front of you taking notes. So when you leave the meeting, take your notes right away on things that they talked about that you need to follow up on. Make sure you grab that staffer's card or your legislator's card so you can call them back. But make sure you always send a thank you. Again, you can do it physical mail or email. Either one's fine. You're not actually expecting a response, so you want to do a good old-fashioned one. It doesn't matter if it takes a few weeks to get there. But always, again, reference why you were there. Reference something to help remind them, the same way you write any other thank you note that your mom taught you how to write. And make sure you reference the bill again, okay? If you happen to be active on social media, thank them there, and especially if they do what you ask them to do. So as soon as I had Pete Sessions saying, yes, I'm going to co-sponsor that bill, you can guarantee that I, on every single piece of social media, gave him props for doing it, right? Whether or not I agree with him on other stances and whether or not I voted for him, it doesn't matter. He's my legislator right now, so I'm going to thank him for doing something that I think is a benefit for my patients and my community, right? And then make sure you're always following up frequently. Keep touching base with that person that you made that contact with so they know what's going on. Okay, biggest thing I get from people is I'm too busy to do this. Staci, you spend a lot of time doing this stuff. You go to DC way too many times a year or drive down to Austin. I can't do this, right? We already talked about a few different easy ways we can actually be an advocate. And then let your organization do the work for you. Let the DPC Coalition do the work. Let AAFP, let ACOFP, AOA, OMED, OPAC rather, whoever you want do the work. Let them do the work for you. Find someone you align with. Again, get on that email list. And on their websites, they are often going to have updates for what's going on with bills. And so it's really quickly to go read a summary, okay? And then pay attention to emails like this. So again, don't look at the date. So Representative Burgess is an OBGYN in the DFW area. The Dallas County Medical Society is really good about supporting physicians and other politicians that are very favorable towards healthcare, specifically doctors, but towards healthcare in general. And they're really good about putting on events where you can meet the politician, and then hopefully you're donating to their campaign at the same time, but you at least get to go have face-to-face with the physician or the politician. So pay attention to emails like this. Make sure you're looking into your state and county or city organizations so that you can be a part of that too, because this is a free way where you get an actual one-on-one. Because, right, there's probably going to be 20 to 30 people at this event versus at the 4th of July parade, there were thousands of people. Okay, so again, are you too busy to do advocate work, or you just think that you don't have time? So at the bare minimum, pick one issue, follow one issue, and do something to help with that one issue. So I pulled just some pictures from the AAFP website. You can go under that advocacy tab. There's lots of great information. So you can see the latest statements that AAFP has made regarding the migrant family separation, the opioid crisis. The one below this is going to be about direct primary care. There's plenty of links where we were talking about how to meet your legislators. There's even more lobbying tips on there. I did not pull these from there, but I'm sure there's some cross between the two. And they also have a bill tracker. So these are I pulled this literally this week. So these are the top issues that AAFP is watching right now. And you notice the second one, that's our bill, okay? So they're giving summaries to the bill, and they also put if they support it or don't support the bill as written. So while you may not agree with everything on an individual basis, if you really do feel you're too busy to actually do this stuff, then this is a quick and easy way to do it and go, this organization in general does support me. If they support this, I'm going to support this, or vice versa. Make sense? Nice, quick, simple, easy. And then if you click on those bills, it actually will give a nice detail about the bill. You can actually read the bill from there, and it talks about the people that are sponsoring it. So one last thing, a big shout out. We are leaders. We are leaders in our clinics. We're leaders in our communities, right? We are leaders. We need to take this time to lead. And it doesn't matter if you decide to do TPC after coming to this conference. You need to step up, and we all need to work together to change healthcare. Hopefully you've gotten the fact that TPC doctors aren't in this to make a lot of money. We're in this to actually try and change healthcare and do things better for our patients and for ourselves, right? So I would hope that my fee-for-service colleagues will continue to support what I'm doing, no matter if it is what they decide they want to do, right? Because they know I'm in this for the right reasons. So be an advocate for others, not just for yourself. So last season, hurricane season, the direct primary care group got together and raised a bunch of money to buy medical supplies. Since we're all used to dispensing meds, we said, well, we can help buy meds and buy medical supplies. And this is me and then Dalian. Dalian's not here. She's a DPC doctor in the Miami area. We ended up raising over $30,000 within 5 days. In total, between Texas and Florida, and then some scattered docs across the country, but all the stuff got shipped out of Florida and Texas. We helped with Harvey, Irma, and Maria, and it was about $200 million of stuff we ended up shipping down. So that was all grassroots efforts. It was organized via social media, but I have to say it started with the DPC docs group. So make sure you're advocating for those that need you to advocate for them. So now we're going to take some extra questions. If we can figure out which iPad, because they all turned off.
Oh yeah, sorry, confusing the iPads.
Okay. All right, so the website real quick about the practices. So he has the link on the DPC Coalition website. It's also dpcfrontier.com/mapper. That's Phil's website. Great information. He's a physician and a lawyer. Has great information about direct primary care on his website.
Don't hold the lawyer thing against him.
Okay, so we have one good question. This is a big point I think we need to talk about. So as it stands, HSA cannot be used for DPC.
That is the interpretation of the Internal Revenue Service, yes.
Take that. All right. So go to Phil's website. Okay, so if your individual membership fee is $170, could someone with an HSA use their HSA up to $150 and pay the extra $20 out of pocket? And I asked this because this question was not on there before I started talking, but a lot of people have flagged this up.
Yeah, as it's drafted, no. The definition of the cap is tied to the definition of what fits that exception. So again, what we're hoping to do is to move that cap, and I do believe there will be a cap in this legislation, to the amount of pre-tax dollars that can be spent. So the IRS would simply say up to $150 or $300 for a family can be spent on a DPC practice. But as it's drafted today, you would not, you're, again, solely for your patients with HSAs, you would not meet this exception if you charged $170.
So I'm going to just read some questions. These are simple answers. Is the HSA contraindication only for membership structures, or would direct pay for specific visits like a cash-based fee for service be implicated? No, it's just for the membership piece. Like we said already, your fee for service items, if I charge extra for a joint injection, it's the only thing I charge extra for. People can use their HSA for that right now.
Yeah, you can already use your HSA for that stuff.
And again, look at Phil's website to read more or talk to us off stage. What does medication besides vaccines mean? It means any medication besides vaccine. And then there's a Medicare question about opting out, but Phil, you're covering Medicare and all the opting out, right? So we're going to leave that to Phil. Let's see. There's another question here about dispensing medications in the state of Texas. Just come find me afterwards. When talking with the legislator, after offering your opinion on a bill or proposed legislation, ask if there is anything a legislator needs on the issue for your organization. They often need and are anxious to get supporting information to help move the bill. Very true. Very good point, whoever made that out there.
Absolutely. And another word on just the general follow-up. It's likely that when you go into one of these visits, they're not going to get right back to you. You know, sometimes they'll answer you with a form letter, sometimes they won't answer you at all. So it is really important to keep on the staffers.
Yeah, and be persistent.
You know, be persistent, but don't be a pest, right? So you gotta draw that fine line. So maybe a call every day or an email every day isn't good, but you know, maybe once a week is.
Mm-hmm. And it took being persistent, but finally one of my colleagues in Dallas got an email set up with Mark Cuban to talk about direct primary care for the Mavericks. So you never know, weird things can happen. If you charge per visit fees that are not membership, is this covered by HSAs? Yes. And then one last question. Assuming that the Primary Care Enhancement Act passes in an acceptable form, what is the next major focus for the Direct Primary Care Coalition at the federal level?
That is a great question. I thank you to whoever planted that, because we're already really involved in this. I think, as you all know, CMS has put out a request for information about direct provider contracting relationships, and while we were very unhappy that they sort of stole our acronym for that RFI, we're really excited about the idea of doing a DPC demonstration with the Center for Innovation in Medicare. So I would say, first and foremost, it's going to be not just Medicare, but working with other payers, working with providers, working with employers in particular on growing your patient base. People with Medicare, people with Medicaid at some point, even though we've heard about all the pitfalls. You know, the silver lining of the demise of the Q-Liance model due to the problems that they had with Medicaid, I think taught us a lot of great lessons about how to do it. And the way to do it appropriately is to make sure that we have an even footing as primary care with the Medicaid plans that are now in almost 100% of states, and with the state. So there's got to be a three-way relationship when we're setting these things up. So Medicare, then later, after we do Medicare, Medicaid. State employees, I think, are going to grow dramatically, and we will still have state legislative battles to fight in terms of passing some of the laws that define DPC as a medical service and not insurance. I think the landscape on the states is pretty good right now. I don't think, and Phil will talk a little bit more about this, I don't think there's a lot of states that have an outright prohibition on DPC in any of these states. But there's a couple of other reasons why we want to continue to pursue this. Number one, it's obviously really good advertising. You know, if you're going to pass a DPC law in your state, you're going to see some growth. You're going to see some interest in getting other fee-for-service docs to move into DPC, and you're going to see a lot of interest from employers. Interestingly enough, one of the key supporters of most of these bills out in the states has been the National Federation for Independent Business. Why? Because small business owners are really struggling to figure out a way that they can provide a really good health care benefit to their employees without facing these huge premiums that they have to pay. So DPC is a real part of that solution. We really want to help grow that with employers and with other payers, and in particular working with CMS.
So thank you, guys. Just one last reminder, if you've seen one DPC practice, you've seen one DPC practice. So not every bill is going to be what every practice needs, but we're always working to support the movement as a whole. And remember, we always want to be cordial and respectful to other DPC docs, organizations, institutions, whatever it is. We always want to be respectful and fight together.